Welcome to the next Ask the Experts COVID-19 virtual town hall. This is our 7th town hall, and it's been over a month since we had our last one. And these town halls are certainly popular. We've had over 600 participants in our recent ones. My name is Tom Pichota. I'm the Vice President for Research here at Chapman University. I'll be moderating this town hall where we have some great experts. We'll be hearing about current issues from a wide range of disciplines that I'll talk about here in a second. Certainly, there's many interesting issues happening in our community right now, whether that's how do we mitigate against the coronavirus, how do we mitigate against the recent resurgence of cases, and just some of the interesting research that our faculty are working on. And I think that's what you'll hear about today. Here at Chapman, we have a lot of activities going on, even though the campus has been somewhat closed. I was excited today that we were actually to open up a little bit of our research activities for the campus as part of our phase 2 research reopening in limited areas. So some of our laboratory research was able to restart today. One of our faculty members who you heard from a month ago, Dr. David Frederick, he had a large mental health survey that just received a lot of broad attention and actually was published or was written up in Newsweek. So we're really excited about the work that our faculty and students are doing. And as I said, you're going to hear from a broad group of experts from Chapman today talking about their area of research with COVID-19, whether that's from the fields of School of Communication, psychology, political science. I'll be introducing each one of them as they speak. And we look forward to hearing the interesting questions that you'll have. You'll have opportunities to present those questions. There's a Q&A feature on the Teams application there that you can, right now you can start posting questions if you want. So feel free to do that, and our presenters will either respond directly to you or we'll get to those as part of the second half of the Ask the Expert presentations here. So with that, let's go ahead and get started. Our first presenter is Professor Jennifer Bevans. Professor Bevans is a professor in the School of Communications. She has expertise in individuals' close relationship with health issues. And today she's got some really interesting work that she's doing in her background and expertise in family caregiving and the stress that COVID-19 has created on that. So with that, I will turn it over to Professor Bevans.
Hi, thank you. Thank you, Tom. So today I'm going to talk about COVID-19 related family caregiver stress, preliminary findings from a national US survey. The first thing I want to do is to give some love to my co-author and collaborator, Dr. Hannah Ball, who is an assistant professor in our school. She and I worked on this project together, so I wanted to say thank you, friend, for your hard work on this project. So first off, I want to talk about what an informal caregiver is, who they are. There are 53 million Americans who are currently informal family caregivers in the United States, according to a recent survey by NAC, which is the National Alliance for Caregivers, and AARP. They can be defined any number of ways. When we define them in our research, we do a pretty broad definition of them because people don't typically identify themselves as caregivers. They tend to see that as a formal term, someone who works maybe in a healthcare facility, a nursing home, etc. So we tend to not to use actually the term caregiver. We say someone who provides regular care or assistance to an older adult family member who has a health problem or disability. Some examples of types of things that caregivers do are unpaid personal and medical care, chores, arranging for financial and outside services. So to talk about the particular survey that we conducted, we did an online Qualtrics survey, which did a national panel looking specifically at individuals who care for their family members, looking specifically at older family members, 65 plus. We had 277 participants, and the notable thing to look at here is that we included the dates of 4/21, April 21st to April 30th. This was when the pandemic was pretty much across the United States. Most states had stay-at-home orders or safer-at-home orders, and the pandemic was pretty much known nationwide. People were experiencing it. There were tens of thousands of deaths at this point, and people were, in the throes of it. So it was a prime time to be collecting these data. Our caregivers, who are our participants, just a snapshot of who they were 51% female, 77% white. Their average age was 46 years. The range was 18 to 88. 44% of them work full-time. So to give you a little sense of who they were as caregivers, 69% of them served as the only or the main caregivers in their care recipients' lives, and they did so for 22 hours per week. So to contextualize that, note that that's almost a full day per week that they were providing care solely for their care recipient. The care recipients that they reported on were 68% female and average in age of 77 years old, and the range was 65 to 100 years. They were caring mostly for their parents or their in-laws, and the majority of their care recipients had either some type of dementia or Alzheimer's or mind deterioration issues and or mobility issues. But note that the caregivers could report that their care recipients had multiple health issues, and many of them did. So this was the snapshot of who we were measuring and taking into account when we were looking at our survey. In terms of our COVID-19 measures, we looked at 3 different aspects. The first question was just a simple one item question that we asked our caregivers. And note that these were also all at the end of the survey. We asked all the questions about caregiving first, and then put these at the end of the survey because we didn't want to sort of get COVID-19 into their minds, although I'm sure it was on their minds throughout as we measured these COVID-19 measures. So the first question we asked was, to what extent have your caregiving responsibilities and decisions been altered by the current COVID-19 coronavirus pandemic? And we made this a slider question on the online survey that ranged from 0, meaning none, to 100, meaning full extent. The mean was 51.68, so it was a moderate extent to which their responsibilities and decisions had been altered. And then, keeping in mind, this was mid to late April, and the range was 0 to 100. So some were not bothered at all, and some were fully altered. The second thing we asked was, we adapted a caregiver-related stress scale that was already in existence from Cousins et al. 2002 to basically focus on COVID-19 stress. And we did that by asking in the directions to focus on how they had been experiencing their COVID-19 pandemic issues, focusing that on their experiences with caregiving. 3 items basically assessed, stress related to activities outside of the home, how that was impacting their caregiving activities related to visiting friends, social activities, etc. Both of these scales ranged from 1 to 5, with 5 being the highest that they could be stressed. The mean was 3.66, which is moderate to high. For the internal factors related to caregiver-related stress, these were the ones that were focused on the relationship with the care recipient. So the extent to which the stress was focused on pressure, frustration, nerves, and helplessness associated with taking care of the care recipient as related specifically to COVID-19. And again, 1 to 5, with 5 being the highest level of stress. The mean was 2.55, so moderately stressed. The next thing that we did, and again, these are very preliminary figures, we looked at how these caregiver-related stress statistics, or these caregiver-related stress means, were related to 2 relationship indicators. The first one was relationship satisfaction, and these were both established measures, and the second one was resentment, both focused toward the care recipient. Please note that these are essentially general assessments. So general assessments of relationship satisfaction and general assessments of resentment toward the care recipient. We found that the internal factors, so the relationship toward the care recipient and the COVID-19 stress, there was a significant and very strong negative relationship toward with relationship satisfaction. So these care recipients were feeling, or these caregivers were feeling, a negative relationship with relationship satisfaction with their care recipients. And there was not a significant relationship with the external factors in relationship satisfaction, which makes sense because that was not something that they were specifically experiencing toward their care recipient. In terms of resentment, we again found very strong relationships with the internal COVID-19 stress scale and resentment, that correlation is extremely high. And another positive correlation with the external factor and resentment as well. So again, this is just a very preliminary study that we're just kind of getting our hands into in terms of the data, but we are just kind of stunned, I guess we could say, in terms of how much these COVID-19 stress indicators are already having an impact on the relationship between the caregiver and the care recipient. We think this is already something that is so stressful for the both care members in the relationship, the caregiver and the care recipient, already emerging in April of this year. And we're hoping to do more research to find out more about how this relationship is progressing and how COVID is going to, continue to impact the caregiver relationship. So I thank you for your time. And if you have any questions, including anything about caregiving at all, this is what we research. Please contact me at my last name at chapman.edu. Thank you.
Great, thank you. Thank you, Jennifer. And also, if you have questions, feel free to post those into Q&A as we move through our different experts. Our next two experts are also from the School of Communication. We have a great representation from School of Communication today. I'm going to introduce both of them because they're working together on some interesting work. Our first one is Dr. Riva Tukachinsky. She's an associate professor in School of Communication. She has expertise in how people process information from the media, and she's going to be presenting with Dr. Megan Vendemia, who's an associate professor in the School of Communication also, and she has expertise in social and psychological implications of communication technology. So the work that they'll be presenting is a project that examines the effects of news consumption on COVID-19 protective behaviors. So I'm sure many of us will be very interested in that because we're all watching the news and getting COVID information from that. So with that, I'll turn it over to Dr. Tukachinsky for her presentation to start.
Hello, and thank you so much for joining. And I will be co-presenting with Dr. Megan Vendemia. So our research project today looks at the factors that predict people's engagement with various protective behaviors related to the COVID-19 pandemic. And what we know from research on previous outbreaks and epidemics is that what really motivates people to engage in precautionary actions is the fear of being impacted or the perceived risk of the disease. And media plays a key role in promoting those feelings. What is particularly interesting is that it's not necessarily that the media makes people more afraid for themselves and therefore they want to take on precautionary actions. That happens too. But also, curiously, sometimes it's the perception of others' response to the pandemic is what's going to drive people's behaviors. So as you are watching the news, you are making inferences about what other people feel, think, and act, and you will behave and take precaution based off that perception of others. And that's what we wanted to investigate. Yeah.
Riva, I'm going to interrupt for a second. Did you want to share your screen?
I believe I'm sharing it. It's
okay. If we're not seeing it right now, but I can always. Oh, there you go.
You do now? Okay, so let me try it again.
Go full screen on that.
Okay, do you see now?
Perfect. There you go. Okay. Yep.
So, specifically what we wanted to see is how does news exposure influences people's perceived threat to themselves, as well as their beliefs about other people's perceptions of threat. How do those beliefs influence people's taking precautionary action, and to what extent we can see differences between different types of precautionary actions. So specifically and uniquely in our study, we distinguish between socially desirable and perhaps less desirable behaviors. So the socially desirable ones would be basically heeding the CDC recommendations, and the undesirable ones would be things like stockpiling essentials, depriving others of accessing those foods or household items, breaking the chain of supply, or acquiring weapons, which is intended for self-protection, but we also know that it can lead to an increase in suicide rates, especially with all the other pressures going on at the same time. So we conducted a survey using a Qualtrics panel that was matched to the US population on key demographics. And these are the variables that we will be talking about. So we looked at news exposure, perception of threat to oneself, and how others are believed to perceive the threat. Engagement with 12 different precautionary behaviors, key demographics, and we do not report today in this presentation a couple of other variables that we have measured. So, but if you are interested in that, we can speak to some of that in the Q&A. First, we wanted to kind of reduce the 12 behaviors into groups, into categories, and we use a statistical procedure, a factor analysis, to see which behaviors kind of group together. We have a physical distancing, so things like postponing travel and staying apart or physically distancing from each other. Hygiene behaviors like hand washing and sanitizing surfaces. So those would be the CDC recommended behaviors. Interestingly, stockpiling was a behavior on its own. It wasn't driven by physical distancing. People didn't stockpile because they wanted to reduce the number of trips to the store. Weapon acquisition is not surprisingly its own thing. And curiously, facial masks didn't group with hygiene behaviors, perhaps because the data were collected at the end of March, before the CDC changed its recommendation to wear facial masks. So there was still uncertainty about how effective they are. And in fact, having a facial mask could have still been seen as a negative thing, because it deprives medical professionals from access to this very important resource. And as this cartoon demonstrates, having a mask was just as COVIDian behavior as ordering toilet paper. So before we jump into testing our hypotheses or looking at our research questions, some general information about what predicts people engaging in those precautionary behaviors. First of all, not surprisingly, with age, individuals were more likely to engage in the CDC recommended behaviors. So all the behaviors related to hygiene and physical distancing. So people who are more at risk for adverse reaction were also more mindful of that. But they were less inclined to engage in any of the undesirable behavior, including facial masks. Also, not surprisingly, conservatives were more likely to acquire weapons, and women were less inclined to wear facial masks. Perhaps, again, because it was still before the explosion of fashionable items that will be also considered to be a protective gear. So perhaps it would be different now. So now to test our research questions, I will pass it on to Megan. Please take it from here.
All right, thank you, Riva. So as Riva had mentioned, we were interested in how news consumption and perceptions of threat, both regarding oneself and beliefs about others, impacted a series of behaviors related to COVID-19. So in order to test this, we first explored to see if there was this main effect of news consumption on these particular behaviors. So we wanted to see if just consuming news itself would increase the likelihood of adopting any of the behaviors we mentioned before. And we found that as news consumption or news exposure increased, that increased the likelihood of adopting any one of those behaviors. In addition to this fairly robust main effect of news exposure causing people to adopt these various behaviors, we sought to explore whether threat to oneself versus beliefs about how other people were feeling uniquely predicts enacting very specific behaviors. So first we looked at how participants' own feelings of threat impacted each behavior. And what we found is that news exposure through one's own perception of threat predicts some of these protective health behaviors, such as wearing a facial mask in public, engaging in physical distancing practices such as maintaining 6 feet distance from others, and engaging in some hygiene behavior, specifically disinfecting and using hand sanitizer. It is worth noting all of these 3 behaviors are considered health behaviors that would protect oneself. So it makes sense that these would be behaviors that would be adopted if one feels threatened. In addition to that, we investigated how participants' beliefs about the extent to which other people might feel threatened would impact certain behaviors. And what we found is that news exposure, through the extent to which participants assumed other people felt threatened in the situation and felt threatened by COVID-19, predicted behaviors related to seeking protection from others. These are, I will note, these are not specific to health necessarily. These 2 specific behaviors that this predicted were things such as stockpiling toilet paper and additional food, and perhaps weapon acquisition. So in conclusion, there seems to be this complex relationship between one's own beliefs and feelings about the health threat of COVID-19 and assumptions about the beliefs that other people might have, or assumptions about other people that are driven by the media. All factoring into one's intention to actually engage in some of these various protective behaviors, some of which are directly related to health and others to a lesser extent. So when one feels threatened, we found that people are engaging in this kind of more positive behaviors, this more positive drive, encouraging protective health behaviors. However, making assumptions about the effect of media on others is somewhat counterproductive or may encourage some socially less desirable behaviors or non-health specific behaviors. So thank you so much for your attention. We look forward to addressing any questions you might have in the Q&A session.
Great, thank you so much for that interesting work, and I'm sure we'll have lots of questions around that. I want to move on to our next speaker. He's a returning ASCII expert panelist, Professor Andrea Mully from the Department of Political Science. He has expertise in religion and politics, international relations, religious violence, disaster studies, martial arts, and warfare studies. He does some really interesting work, and his work is around how COVID-19 addresses complex social factors that affect the spread of COVID-19 in Europe and the US, and he'll be talking some about that today. So with that, I will hand it over to Professor Mully.
Thank you, Tom, for having me for the second time here. So today, I don't have a specific research that I want to present. I just wanted to talk briefly about the work that I'm conducting on, as you were saying before, the social science of COVID-19. I do have currently 3 different projects that are looking at this aspects from a very slightly different perspective. I use in different methods, statistical analysis or computational simulation. There are different stages of submission or different stages of work. So the work is currently supported, as you can see from my first slide, by the Social Science Extreme Events Research Consortium, which is based in the University of Colorado and is supported by the National Science Foundation. And these are the top social science initiative in the field of natural disaster and biohazard events. So I'm pretty excited of being part of this initiative. So again, I was saying before, my focus is primarily on the United States and Italy, partially because Italy is my own country, so I keep a really close eye to what is happening over there, but also because I think it's a very interesting study case for a lot of reasons. It has become sort of ahead of the curve in this whole pandemic event. My goal is to offer social science perspective, so I will sort of like go beyond some of the individualistic assumption of medical epidemiology and focus more on my attention on the complex social interactions that are involved in the spread of COVID-19. Starting with the cultural context, one of my research is particularly focused on this and includes the impact of social and cultural norms in both the spread of the COVID-19 and the mitigation efforts, so that we understand each other. When I'm talking about cultural and social norm, I do talk, for example, example, about the physical, the predominance of certain physical contacts versus other way of interacting. In case of greetings, for example, Italians tend to be more hands-on and kiss each other and then shake hands. Well, some other cultures might be more or less inclined to that kind of affection, but also the frequency of mass gathering that is more evident in some cultural contexts and society than other. As we were saying before too in the previous presentation, also the diffusion of some hygienic norm, such for example the use of mask, which is very widespread in many Asian countries, but is not as widespread in the United States and Europe. The second thing that I'm focusing on is the social structure. We'll talk about this a little bit today, such as factors such as the age of the population, the occupation, the dependency, especially the level of intergenerational dependency that's very clear in Italy. So we could between different generations of individuals. Then we're looking at social networks, which we feel is particularly important to evaluate and predict the spread of COVID-19. So we're looking at the size and density of network, as well as the composition, and also, which I used a different box for that, also what we call the neighborhood effect, which is the way these social networks are embedded in physical location. Think, for example, areas in which transportation and moving of people is more based on public transit versus area which is more based on private cars, but also the prevalence of smart working, as they say in Europe, or remote working, as we would say here in the United States. And finally, which appeared to be a hot topic recently, how the political landscape affects spread and mitigation. So this is all both in terms of the impact of political landscape on short-term policies, and especially containment and mitigation strategies. We're seeing now a lot of evidence that red states tend to be doing a worse job than blue states in containing COVID-19, but also long-term policies such as the preparedness of emergency or the funding of the AL care system. So these are some of the things we're looking at in our research project. Now I'm going to go over very briefly on some of the findings that looking at the data. So one of the things we observe more is that we have more COVID-19 cases in those areas that have a younger, more active population. This is, for example, explained by the prevalence in those areas of public transportation or alternative form of mobility, but also higher probability of getting to public events or public mass gatherings, and possibly the prevalence of pre-symptomatic or asymptomatic. This is really not clear what is the mechanism over there, but the prevalence of pre-symptomatic super spreaders, which in turn impact the mass gathering. Another thing we observe is that we have more COVID-19 cases in those areas that have a higher intergenerational dependency. As a matter of fact, there are some deviant cases here in some areas of Italy. We found that the higher the intergenerational dependency, the lower is the number of cases. So we still have to explore that. But again, it correlates to the size of the family, the density of the family, the policies in the state, whether or not they offer services such as babysitting, or it's the older generation that have to take on that, and also that will feed into that idea of super spreaders or young spreaders to get more on the, let's say, to get more responsible for getting the virus number going up. The other thing we observe is that we have more COVID-19 cases in those areas that have an uneven wealth distribution. This probably doesn't come as a surprise for anybody, but when we see more deprived and marginalized population, we also see higher rates of infections. And we see that both in Europe and the United States, but the mechanism is a little bit different. Looking at the United States, it has to do more on physical segregations, higher quota of individuals that are employed in sexual activities, which we know are more exposed to the contagions, and generally in less access to health care, which also contributed to the higher incidence of pre-existing conditions. So what we see here, we see both more cases and higher mortality, which kind of look into that, point us to look into that idea that maybe we should look more on the lockdown or stay home as a privilege more than an opportunity for everybody. A couple of more things. We observe more cases consistently across geographical macro regions, both in the same countries and also across several countries. For example, New York City and the city of Milan, which is the financial capital of Italy, tend to have the same pattern, and that is because, of course, they tend to share many things in common, both on the social aspects and factors and the natural environmental factors that are more conducive to higher infection rate. And last but not least, we do not observe more COVID-19 cases in those areas that are more dense per se. I may be clear about this because I'm not saying the density doesn't matter, but the moment you, for example, in a statistical model, the moment you threw all other proxies for social interaction, social network, neighboring, cultural activities, social norms, the effect of density tends to go away. So what we see is that not about density per se, it's about what you do with density, what would actually provoke density in the first place, and then sort of help us explaining why we do have areas that are very dense, but they don't show high level of infection, such as the city of Tokyo, for example, Osaka, Nagoya, or other city in East Asia. And you still have, for example, in Midwest America or Wyoming or Texas, areas where the density is not that big, but you still have an increasing and higher number for infection. So we'll take one more minute to some final remarks. What I want to point the attention here is that we think we need more tailored policies to deal with COVID-19 and the mitigation strategies, as well as a recovery. We cannot consider a policy that covers everything. We'll say one size fits all sort of policies to cover, for example, all the United States. That doesn't mean that we don't need a coordinated health communication strategies, or we don't need to provide national targets to assess the effect of whatever policies we deploy at a more lower level. The other two things that we want to emphasize as a research group is that let's stop talking about social distancing, talk about physical distancing, and let's emphasize less the curve, but more the curves, because there are different curves, not only different countries, but within the same country, within the same state, even within the same county, we have different curves of COVID-19. And that will be it. Thank you very much for this opportunity and for listening to my presentation. If you have any questions or think you want me to go a little bit deeper with you, please contact me at my last name at .chapman.edu. Thank you.
Great. Thank you so much, Dr. Amole. And please, if you have questions for him too, you can also post in our Q&A. And our last presenter is Dr. Uri Maus. He's an assistant professor of computational neuroscience and psychology in the Korean College of Health and Behavioral Sciences, and also in the Brain Institute. He has expertise in neural underpinnings of volition, how desires, decisions, and intentions transform into action. And he's doing some really interesting work with a large collaborative group on tracking psychological, economic, legal, and other trends related to COVID-19 that he'll be talking about today and is supported by the K Family Foundation. So with that, I'll hand it over to Dr. Maus.
Thank you, Tom. Yes, as you mentioned, our COVID dynamic team is quite large. Besides some students here at Chapman University, we have collaborators at Caltech, Yale, Adelphi University, and the City College of New York. So this project is a longitudinal study. We've had 7 waves so far, every week in April, then every 2 weeks in May, and then now we're going into June. We cover the United States only, all 50 states. We have more than 1,000 participants in each wave, and we plan to cover all of 2020, budget permitting. We look at various measures in each survey. So the survey takes about an hour, sometimes more, for each participant. And so we look at things like depression and resilience, and as well as general disgust. We also look at questions related to free will, which is a particular interest of mine, and we're wondering what happens to free will when you're under lockdown. We also devised some of our own measures from personal background to some specific discussed related to COVID, and I'll mention later some COVID vignettes that we looked into. Besides asking survey questions, we also have our participants do various tasks. Perhaps more famous among them is the implicit association task. So our survey basically included people who chose to participate in it on this prolific platform that we're using. And I guess one question that we wanted to understand for ourselves is how representative they are of the US population. Well, if we look into states, generally speaking, they are representative, although we can see that states like California, Oregon, and Washington are overrepresented, while states like Arkansas and Utah are somewhat underrepresented. If we look at ethnicity, we can see that white and Asian populations are overrepresented in our survey, while Black or African American and Hispanic or Latino populations are underrepresented. However, we are most skewed regarding age, and we can see that we are skewed younger compared to older. So almost 3/4 of our population is below the age of 50, while that's only about half the population in the census. And older people make up less than they do. Now, I'll talk a little bit about our results. Oh, I should say that in terms of gender, we are roughly 51 to 49, as is the general population. Now, I'll tell you a little bit about our results, but I want to point out that all of these results are, of course, preliminary at this stage, and this is an ongoing study. So one thing we looked at is how much does COVID-19 impact income? We asked people to report their income in 2019 and compare that across the different waves up to and including June. And well, we can see, perhaps not surprisingly, that incomes have gone down. We can see that people making less than $250 a week, it was 27% reported in 2019, while now it's 43%, while people making more than $1,500 a week went down from 17% to about 10%. On average, our participants lost $193 a week, which is over $10,000 a year. One other thing that we've seen, if you look at disgust scales and even more fear scales, you can see that with our waves, you can see fear going down, fear of the disease, fear of COVID, which might explain things like the mask wars we've seen in Orange County and elsewhere. We've seen worries that people are no longer adhering to physical distancing or otherwise, and then we've seen some states where numbers have been going up in terms of cases, deaths, and so on. One thing that we also looked into is norm internalization. There are some new norms that we are all facing now. You have to or not wear a mask, social or physical distancing. For a long time, people were not supposed to leave their house for non-essential reasons. So we could ask about those things explicitly, ask, is it okay? To what extent is it okay to leave your house for non-essential products and so on? But there are some issues with asking people specific questions. Sometimes people are uncomfortable if their views are unpopular to share their view. At other times, people's behaviors are just really driven by implicit views, implicit biases. So we wanted to look at those as well. The way we did that, we started with something that's not related to COVID, just a scenario like the following, or a vignette like the following. So let's imagine there's a company, and on the receptionist desk, there are 2 pens. And according to the kind of regulations in that company, it is okay for the receptionist to take one of those pens and walk away, but it is not okay for anybody else in the company to take a pen and walk away. That should be left on the reception desk. However, one day, Jess, the receptionist, takes the pen and walks away, but also Parker, one of the workers, takes the pen and walks away. And at that time, an important client comes in, needs to sign off on some, let's say, important contract, and there is no pen on the reception desk. Now, if we ask people who is to blame, then people who have internalized the norm would tend to say that Parker is to blame because Parker should not have taken the pen while it was okay for Jess to take the pen. So then we do similar things with COVID vignettes. We say that two people go into the pharmacy, and this was done when it was not okay to leave your house for non-essential things, the specific vignette. And then we have one person going in for insulin, the other person going in for air freshener, and they go into the pharmacy. They are both asymptomatic with COVID-19, carrying the disease, not knowing about it, and they get the pharmacist infected, who is then seriously ill. And then we ask, so who is to blame? And that is a way for us to see how people internalize the norms without asking them that explicitly. I'm not going to go into the details, but just to say that we do see some kind of implicit internalization of the norms. Another thing that we've looked into, we've had our participants in the survey answer various questions about these COVID vignettes, and then in the end we said, well, can you explain your answers overall? And we left it like open text, and what we wanted to see how serious they were taking it, how much we can understand from the open text what they would have answered. So we had a small army of research assistants, mainly from Chapman University, help us with that. We only gave them the open text answers that the participants gave us, and we asked them from that open text, can you predict how they answer the different questions? And what you can see here is they could predict it relatively well. These are the differences between what the students predicted and what the actual answers were, and you can see that it's around 0, so there's no difference on average, at least. And I would like to just thank the various students who have helped us with this, mainly from Chapman, although from elsewhere as well. And to note that much more can and of course will be done with this data set, and you can find more information about it also on the OSF website under this name. And I'd like to thank you for listening, and if you have questions, you're welcome to ask them here or later send me an email. Thank you very much.
Great, thank you so much, Dr. Miles, and thank you all for the interesting presentations. I know some of you in the audience have been posting questions already and getting answers from our panelists, which is great. I'm going to ask a few more. We have a little bit of time left here, which is great to be able to ask some of the questions of our panelists, and I'm drawing this from some of the interesting ones you all have posted. I'm going to start with Jennifer, who gave a nice presentation on family caregivers and the additional stress created by family caregivers. I guess the question, there's many probably in the audience that are family caregivers and feel the stress that you were talking about. And I don't know if you necessarily have the background for this, but maybe based on the information that you've gotten in the surveys, what would you say to them in terms of coping mechanisms that you see family caregivers, and it sounds like with COVID-19, it's already a stressful environment that family caregivers have. COVID-19 has introduced an additional kind of level of stress, even if you're not a family caregiver. What would you say to people that wanted to understand what are the right coping mechanisms for that?
Yeah, that's a great question. A lot of family caregivers actually don't take advantage of the formal support services that are available for specific illnesses that their care recipients have. For example, Alzheimer's organizations around the country and locally here in Southern California are just wonderful resources for caregivers. And I know that they are really gearing up specifically with COVID-19 resources and have things obviously online. They have a lot of online webinars and a lot of online support groups now that are even easier than ever before for caregivers to access. So I would say to take advantage of some of those online resources. I know it's hard with the timing, but if you have an hour here or there just to take advantage of those, I know that those formal services are really, really helpful according to the research. So that's one thing that I would say, and a lot of those are geared specifically to whatever illness or health condition your care recipient has, so they can be really, really targeted. The second thing I would say is, and I would say this to all Americans who are having issues, and that's a lot of us, is to seek out some formal help. I know that formal help is something that we can access a lot more easily these days with telehealth. Mental health is very important, and we are all definitely dealing with different issues, and it's emerging for a lot of different people in a lot of different ways. I heard that people are having a lot of increase in rosacea these days as an instantiation of their mental health. So that's a new thing I'd never heard of. But you can get on the phone with a doctor and talk to them on Teams or Zoom or Skype, and it's just a lot easier now than it ever has been before. So I would say to talk to somebody, and as a caregiver, you're doing that for yourself and for your care recipient. And the third thing I would say, just to wrap that up, is to take whatever your state says about your orders and probably nudge that as far to the extreme as you can, because again, you're doing that for your care recipient as well as yourself. So if your state is saying recommend wearing masks, I would say require wearing masks, because you have to keep yourself healthy and you have to keep your care recipient healthy. So those would be my recommendations.
No, that's great. And certainly healthcare has changed for a lot of people in terms of telehealth, and certainly for senior populations, that's a very different way of now having it, and having a family caregiver side by side with them is probably really important for that to happen, because telehealth is something that's new. I think the next question I want to have is for Riva and Megan, and you discussed some interesting work that you're doing with media and how we get information from media. I guess the question I have, and I think someone posted something along these lines, but I think the question is, how much of those behaviors that you were describing and the behaviors that people respond to and the information they get from that, how much of that is driven by people inherently wanting to get information from media sources that they know they're going to get that answer from the media sources, whether that's a liberal-based media or a conservative-based media, and how does that really drive behaviors that people have in terms of whether that's health behaviors or protective behaviors that you were showing also,
Riva, do you want to take a stab at it? Okay. Okay. So I think there's a few things going on. One, we looked at each of the news organizations to give you kind of a better picture of what type of news outlets are available. We had things like from watching Fox News to watching MSNBC, CNN. We had all these different types of news organizations with their own biases, for sure. We treated this as an aggregate and looked at how much news overall on a 7-day week you were consuming from various different types of outlets. And that included things like social media as well. And we looked at all of these different behaviors separately to see if there was anything going on. And it seemed to be that we were getting the same finding, that was predicting, we were getting the same pattern each time we ran the analyses. While we did account for political ideology, we controlled for that. It's a significant control variable to include in these analyses. But it would be interesting to look further in the types of content that people are consuming. It's hard for people to say perhaps what they were consuming, especially during those earlier times when we collected this data, when there was a lot coming at you from all different directions, whether you were seeking it or not. It would be interesting to see the types of content that people are actually consuming, but this was kind of the best estimate to get at, especially the recommended behaviors, the CDC recommended behaviors, along with other things that people were hearing about at the time, which is how we kind of developed that measure, including various things that were recommended and some were not recommended, but they were things that people were talking about in various media outlets.
I want to follow on to that too. Do you see, since you identify CDC measures, do you see anything in the way people get information in terms of it changing in terms of the way, whether it's science-based government agencies like that, or the way science is providing information like that? versus media, and that changing because of what's happening going on with the pandemic, changing in either a positive way or a negative way.
So we, once again, as Megan was saying, we didn't measure specifically the content that they were exposed to, so we can only extrapolate that from other things. What we did look at, and we didn't report here, we are still looking into this data. We looked at things like to what extent people believe that the threats are exaggerated, and also their sense of trust in various authorities, including the government, the state government, the federal government, the health authorities. And as far as I recall, in general, media exposure or news consumption overall is positively associated with greater trust in the medical authorities. And by extension, they're then heeding the CDC recommendations. So probably having a lot of CDC sourcing the information in the media is it pays off. It's reassuring. And so even if some of the results are kind of commonsensical or things that you would have expected, I think it's still reassuring to see that those things do work in the real world, because not always that is the case.
Yeah, good. The next question I want to ask is for Professor Mole. You've done a lot of work in both Europe and the US. I guess based on the work that you've done, can you maybe comment a little bit on differences and similarities you've seen in the responses, both in terms of the response rate? We weren't showing any of the data here, but you've probably looked at a lot of that data, but the responses that you've seen in the data, and then the responses, the societal responses to this also between Europe and the US.
There's actually one, thank you for the question. There's actually one of the project that I've been involved with the University of Milano. They ran a little experiment on compliance, neurocompliance, starting from the inception of the pandemic, following up to the ease of the lockdown, and then with the release of activities and people that can pretty much do most of the things that we're doing before the beginning of the pandemic. And so what we've seen compared to the United States, in most European countries, we've seen a strong phase of compliance at the very beginning of the pandemic, when people realize, and mostly is also due of explainable with sanctions that were imposed in case the people were not complying. But we see a much better attitude of people towards simple things like wearing a mask or avoiding to go out or avoiding social interaction. We haven't seen that everywhere in the United States, where people tended to be more individualistic, so to speak, especially the younger generation tend to say, well, who cares? I'm not gonna get this thing, so I'm gonna still go and do whatever I want. But then after the lockdown was lifted, in most European countries, and that includes Italy, France, Spain, the United Kingdom, the only exception is Germany, we've seen an increase of contagion because people just stopped to do whatever they were doing before. With a mask, for example, that's one case that I want to briefly talk about it. Italy used the mask very almost religiously in most circumstances. They even had an obligation in certain areas to wear gloves, plastic gloves, when they were going to the supermarket, grocery stores, or public gatherings. But then the moment the sanctions stopped, they stopped using that. So now they're going out without a mask, or they keeping their mask on their neck, or their hands, or whatever they're doing, but they're not complying to the norm. So the norm hasn't being internalized, as Uri was saying. The norm was simply respected because it was there. In terms of political reaction, I would say Europe in general reacted a little bit better than the United States. United States had 2 weeks ahead of the curve. They simply wasted it. They decided we're gonna wait to see what happened, and so they're kind of chasing the dog out of the house. And I don't want to say it's all bad news, but it's gonna be harder to contain this thing. unless everybody gets into their A game.
Yeah, good. I want to ask Uri a question around social norms, and you're doing some really interesting work with a really large population. If you look out a year from now, and let's say we do have a vaccine, what do you think some of the changes in the social norms look like based on some of the information that you're getting from the survey that you're working on and the collaborators that you're working with and the experiments that you're doing in terms of looking at changes in social norms that are happening because of COVID-19? You know, what do you think that looks like?
Well, predictions are difficult, especially about the future, as they said. But well, I mean, some things. This is not. I mean, not even especially from the survey. I mean, some things that that we see is that working remotely and things like that seem to be more acceptable. It's also perhaps going to be the case that you know, wearing masks, at least in some parts of the U.S., is not going to appear as weird as it was a few months ago. For instance, I mean, one thing that we're looking into, I don't have an answer yet, but one thing we're looking into, if, you know, 4 months ago, let's say, if you saw a person with a mask on the street, then you might expect, I mean, you might actually like shy away from them because, wait, they must be sick or something, right? Why do they have a mask on? Now you might feel actually, oh, that's a person I can feel more comfortable going close to. I mean, actually now, if you see a person without a mask on the street, you'd cross the street, right? So some of our views on these things have changed, and those likely have also, I mean, explicit as well as implicit biases that would change with them. But exactly what they are, I mean, we'll have to do more, you know, we'll have to do more analyses and more studies to see. Also, you know, we've seen some things, and we've seen some things about protests, right? We've actually, I mean, we asked a little bit in week 7 about the protests that were happening and so on, and then how did people feel with or without wearing a mask? You know, so some people were basically saying it's so important for me to go out that I know I'm taking a risk, but I'm going to go out. And but again, we haven't analyzed it yet, but maybe in a few months I can come back and tell you.
Thank you, and I'm going to use that as your last word. I'm going to give all the rest of the panelists the last word, Uri. And I think as for the last word for the panelists, maybe then building off of what Uri was talking about, thinking out keys to how we whether open up the economy, open up the university, and do this in a safe way that people in society can feel comfortable and maintain our health. What do you all come at it from different perspectives and different expertise? What do you see kind of those keys for us to do this safely and don't have a resurgence of cases as we move forward and hopefully get to a point where we eventually have a vaccine? So I'm going to start with Dr. Bevans. Put you on the spot here. Yeah.
I think we have to make wearing masks patriotic. I think it's so important. I think the research, I'm teaching a nonverbal class in the fall, and so I'm going to be focusing the whole class on COVID and how it's just basically changing everything that we know about nonverbal communication. And all the research I'm reading is showing the effectiveness of masks, and it's just such a small gesture, and I just really don't understand why people are seeing it in such a hateful way. It works. And it's for ourselves, it's for others, and it's for our country. So that would be something that I would love to see, because I think it helps with the pandemic and I think it helps with the economy. So that would be my final word.
Great. All right, Riva, you're next.
Well, I think that specifically on campus, our biggest challenge is that the majority of the campus is populated by young individuals who see themselves less at risk, that are less likely to adhere to those recommendations, and I think that's our major challenge. And so the question is how to make those behaviors to be more appealing on a personal level, because once again, this is not a behavior that will be changed by saying, well, you put someone else at risk. It's about the personal risk that drives those behaviors. So I think that's where the challenge. So just like turning the mask into a fashionable item and something that you are Instagramming about, so things like that, make it like a social challenge. I think that's where reopening the campus in a safe way without putting at risk people who might be more susceptible is going to be where it goes.
Great. All right, Megan, you're next. You're muted, Megan. There you go.
So I would agree with Riva as well. I think also just campaigning around this would be helpful, because as you can see with our data that, seeing these messages from multiple platforms, the extent to which you're seeing these messages is important. So any sort of kind of campaigning around that from multiple platforms would be helpful, and designing messages that can encourage protective behaviors, at the same time making people adopt those behaviors and feeling good about adopting those behaviors, I would think would be important.
All right, and Andrea, you get the final word here.
So I mean, getting a final word, I'm pretty much think that I agree with everybody else on wearing the mask, and and not only for COVID-19. I think that's common sense to wear a mask when you have a cold or anything else. I lived in Japan for a few years, and that is pretty much the social norm. It didn't happen overnight. They didn't do it because they weren't doing it in the Dark Ages or whatever is their equivalent of the Dark Ages, but it happened. It came to be at something that now is considered to be the standard, to be the norm. With respect to what you're saying before about the alternative between economy and health, I don't think these are alternative, because I think the social factors are so intertwined with the evolution of the pandemic that we cannot address the pandemic without do something on the social level, and without also doing something that is good for the economy, that will help us moderating, mitigating some of the risks, especially some people have to get more infected and to spread even more COVID-19. I think that's what I would say. And let's keep in mind that flattening the curve was never meant to be. This thing will go away with social distancing. This thing is not going away with social distancing. We're doing this to avoid to clog the healthcare system. The thing will go away, hopefully, either by itself like the Spanish flu, or because we found a vaccine or a cure. Thank you.
All right. Well, thank you all, and thank you to our panelists. Thank you for all the attendees that came on today. Thank you for the great questions. A special thanks to Joey Anderson, Terrence Droop, and Amy Stevens, who worked in the background to make all this really great. And all these presentations will be posted online at the Ask the Expert website, along with the recording of the presentation. And hope you can join us again next time. Thanks. Have a great day and stay healthy.